Usually when we talk about a medical diagnosis, you kind of expect a certain level of mechanical precision, like engineering.
Right, yeah. Very cut and dry.
Exactly.
Hmm.
I mean, you break your arm, you go get an x-ray, that x-ray shows a jagged white line. The doctor just points at the film and says, well, there it is. Broken.
It's totally binary. Broken or not broken. You find the broken piece, you fix it.
Right. It makes perfect sense. You go to the doctor because something has fundamentally failed. But then you step into the world of health anxiety, and suddenly that x-ray machine is, like, entirely useless.
Oh, completely. It's a completely different landscape.
We are looking at a diagnostic landscape today that is honestly a total paradox because we are asking a very strange question. What happens when a perfectly healthy, optimally functioning body causes a patient intense, sometimes debilitating anxiety?
Yeah, it is the absolute definition of diagnostic muddy waters. The biological machine is working flawlessly, but the user manual has been completely misinterpreted by the person living inside that body.
And that is exactly where we're taking you today. Welcome to the deep dive. If you've ever spiraled after entering a minor symptom into a search engine, this one is definitely for you.
We've all been there, honestly.
Right. So we have gathered a fascinating stack of clinical guidelines for this one. We're looking at BMJ best practice, NHS Lothian policies, and guidelines from BHHH, which is the British Association for Sexual Health and HIV.
And these are the heavy hitters when it comes to clinical protocols.
Totally. Our mission for this deep dive is to uncover how doctors handle a very specific yet rarely discussed situation. Like, how do clinicians identify and manage a patient's hyperfocus on normal baseline variations in vaginal moisture, which the patient mistakenly thinks is pathological dryness or an abnormal discharge?
Setting the foundation here is really critical for anyone listening. I mean, we live in a world of profound information overload.
Oh, absolutely.
If you feel a twinge or notice a change in your body, you can look it up and instantly find 100 terrifying reasons for it. And because of this, people often hyperfixate on their baseline bodily functions.
Like staring so closely at something normal that it starts to look weird.
Exactly. So the goal today is to look at what these medical protocols actually instruct doctors to do, demystify the biology, and explore how clinicians go about recalibrating a patient's understanding of their own body.
Let's start with that baseline then. Because before we can even begin to understand why a patient might mistakenly think they are pathologically dry or, that they have some rampant infection, we really have to establish what exactly is supposed to be happening down there on a normal Tuesday.
Right.
What is the baseline we are actually measuring against?
Well, to understand that baseline, you have to look at the physical biology of what the medical field calls physiological discharge, which is really just the clinical term for normal vaginal secretions.
Just a fancy way of saying normal moisture.
Exactly. And according to the BMJ best practice guidelines, this moisture isn't just appearing out of nowhere. It is primarily produced by glands located at the cervix, so the neck of the womb. And it doesn't just sit there. It has a job to do. It moves slowly, continually down through the vaginal canal, and its entire purpose is to keep the tissues supple, moist, and protected.
And we are talking about a specific volume here too, right? I was honestly surprised to see the sources actually quantify this for doctors.
Yeah, they do. In a healthy, reproductive aged woman, the body produces about 1 to 5 milliliters of this discharge every 24 hours.
Which is how much, practically speaking?
To give you a visual, that's roughly half a teaspoon to a full teaspoon a day, every single day.
Wow. Okay.
The clinical description is that it's typically clear or white, it has a mucus-like consistency, and while it's generally described as odorless, the guidelines make a very careful note for clinicians.
What's that?
They note that it can also be slightly malodorous, and that doesn't mean infection. It just means it's a bodily fluid.
See, I love how the NHS Lothian policy explains the deeper purpose of this fluid because it radically reframes the whole concept for me. It's not just random water escaping the body.
No, not at all. It's a highly active system.
Yeah, when I was reading this stack, I immediately thought of like a self-cleaning oven. Or actually a highly regulated self-sustaining ecosystem, kind of like a coral reef.
A coral reef is a brilliant analogy.
Right. Because the fluids aren't a sign of being unclean. And I think that's where so much of the patient anxiety stems from. The fluid is literally the cleaning mechanism itself.
It really captures the active nature of the environment. The moisture is physically sloughing off and removing dead cells. It's mechanically washing out what we might call the bad bacteria.
Just sweeping it all away.
Exactly. But its most critical function is that it supplies nutrients to the good bacteria that live in that reef.
The lactobacilli.
Yes, those are the absolute heroes of this ecosystem.
Hmm.
Lactobacilli are the dominant good bacteria, and they are what keep the whole environment stable.
And the BMJ guidelines explain the mechanism behind this, right? I found it fascinating.
Oh, it is. These lactobacilli maintain vaginal acidity by constantly producing hydrogen peroxide and lactic acid. Wait, hydrogen peroxide? Like the bubbling stuff in the brown bottle you pour on a scraped knee?
The very same chemical compound.
That is wild.
Your body is basically cultivating a bacteria that produces its own localized microscopic disinfectant.
I had no idea it did that.
Yeah, and this lactic acid and hydrogen peroxide create a highly acidic environment,
Yeah.
specifically a pH between 4.0 and 4.5 in reproductive aged women.
Which means what in real-world terms?
Then put that in perspective. A pH of 4.0 is about as acidic as tomato juice or a cup of black coffee.
So the body is intentionally making this environment harsh.
Highly inhospitable, yeah. That acidic pH is a fundamentally hostile environment for outside pathogens. It literally burns out or prevents infections like thrush or bacterial vaginosis from taking hold and multiplying.
This just completely flips the script for you if you're a patient noticing this moisture. I mean, society or some panicked internet forum might make you think, oh no, there's fluid, I'm infected, I need to clean this immediately.
Right, that's the knee-jerk reaction.
Yeah.
But in reality, your body is actively successfully protecting you. It is the reef keeping itself vibrant and healthy.
And that robust, acidic self-cleaning mechanism is the baseline. That's normal.
But here is where the machinery metaphor completely breaks down, though. Because if a car engine runs at a certain temperature, it just stays at that temperature.
Sure.
If this baseline just stayed exactly the same, 1 teaspoon of clear fluid every single day, maybe people wouldn't panic. But the baseline doesn't sit still.
Far from it. It is constantly changing, morphing, adjusting. And that constant fluctuation is the exact trigger for the hyperfocus and anxiety we're talking about today.
So why does this moisture fluctuate so wildly? What is the mechanism actually driving the change?
Hormones. Specifically, the character of physiological discharge changes throughout the entire menstrual cycle, driven by fluctuating estrogen levels.
Ah, okay. Estrogen is pulling the strings.
Exactly. As estrogen levels rise and fall in the bloodstream, the physical characteristics of the discharge shift dramatically. The body is essentially changing the weather inside the ecosystem based on what it needs to accomplish that week.
Okay, let's break down those weather patterns then.
Yeah.
Because the sources divide this into high and low estrogen states.
Mm.
What is physically happening during a high estrogen state?
Well, when estrogen peaks, vaginal moisture becomes significantly more noticeable. This naturally happens mid-cycle during ovulation.
Right.
It also happens during pregnancy or when someone is taking estrogen-progestin contraceptives. During these high estrogen peaks, the glands at the cervix change their production.
In what way?
The secretions become thinner, much more watery, and much more abundant.
But why, though? Why does the body suddenly decide to flood the system with thin, watery fluid instead of the thicker mucus?
It all comes down to evolutionary biology and reproduction. Think about when this peak happens naturally, right?
Right.
Ovulation.
Yeah, getting ready for a baby.
Exactly. The body is preparing for potential fertilization. That thin, watery, abundant mucus acts as a biological slipway. It creates a highly fluid, less viscous channel that makes it significantly easier for sperm to swim through the cervix and reach an egg.
Okay, that makes sense.
Thick mucus would block them. Water mucus acts like a water slide.
That is incredible. And then the sources also mention arousal, which brings a completely different mechanical system into play, right?
Yes, the Women's Health Concern Guidelines highlight that during sexual excitement, the Bartholin's glands step in.
And where are those?
These are two small pea-sized glands located right at the entrance of the vagina, completely independent of the cervix. When a person is aroused, these glands rapidly produce extra moisture.
So it's a localized response.
They're very localized. The biological purpose here is straightforward mechanical lubrication. It aids sexual intercourse and prevents micro tears and pain in the tissues.
Okay, so you have the monthly estrogen wave creating the water slide and the arousal response creating immediate lubrication. But then we have the opposite end of the spectrum, low estrogen states.
Right. And the most significant low estrogen state clinicians deal with is menopause.
Because the hormones just drop off.
Precisely. After menopause, the ovaries stop producing high levels of estrogen. Because that hormonal driver is gone, the overall volume of discharge decreases significantly. The tissues physically thin out.
And how does that affect the whole coral reef ecosystem?
Well, because the ecosystem is losing that moisture and some of those protective lactobacilli, the natural pH can actually rise to 4.7 or higher, meaning the environment becomes slightly less acidic.
Honestly, I have to challenge the clinical expectation here. Because listening to all this, I completely understand why a patient would be sitting in a doctor's office in a total panic.
Oh, it's incredibly confusing.
Right. If the baseline is constantly shifting from thick to watery, from high volume to low volume, from highly acidic to less acidic, aren't we basically asking patients to be biochemists?
Basically, yeah.
How on earth is an anxious person supposed to know the difference between a natural low moisture day in their cycle and actual pathological dryness, or a normal high volume slipway day and a concerning discharge?
That right there is the ultimate diagnostic dilemma, and it is exactly why patients arrive at the clinic terrified. They are carefully monitoring a system that is biologically designed to change, but they are interpreting every natural shift as a system failure.
They see watery fluid and immediately think infection.
Or they feel postmenopausal changes and think disease. This brings us directly to how the clinician has to act as a detective. They have to untangle an anxious mind from a perfectly healthy body.
Take us into the examination room then, because the guidelines are very specific about this clinical assessment. How does a doctor prove to a highly anxious, hyper-focused patient that they are, in fact, perfectly healthy?
It all starts with the history. The BAH guidelines and the Integrated Sexual Health Services policies, they stress that a thorough history is step one.
So not just, where does it hurt?
No, the clinician isn't just asking that. They are looking for chronological patterns. They ask about the time scale, the exact character of the moisture, color, smell, volume.
Trying to map the weather patterns.
Exactly. And crucially, how it maps onto the patient's menstrual cycle. They're looking to see if the patient's panic aligns perfectly with that mid-cycle estrogen spike we just talked about.
And they also ask a very pointed question about what the patient has been doing at home before coming to the clinic, right? The over-the-counter treatments.
Yes, that is vital. They must ask if any OTC treatments, like thrush creams or intensive douches, have been used recently.
This raised a massive red flag for me when I was reading the sources, because think about the behavior of a hyperfocused patient. They misdiagnose their normal cyclical dryness or their normal watery ovulation discharge.
And they panic.
Out of sheer panic, they run to the pharmacy and start throwing over-the-counter antifungal treatments or aggressive antibacterial soaps at a perfectly healthy ecosystem. What happens then?
It's a tragic irony, really. When a well-intentioned but anxious patient starts aggressively washing, douching, or using unprescribed medicinal creams, they drop a nuclear bomb on that delicate coral reef.
Oh, man.
The soaps wash away the protective lactobacilli, the antifungals disrupt the local flora, they artificially alter the pH, making it less acidic.
So they're wiping out the good guys.
Completely. By trying to quote-unquote cure a normal physiological process, they inadvertently destroy their natural defenses. They create the exact irritation, dryness, and vulnerability to real infections that they were terrified of in the first place.
That is wild. They are literally manifesting the disease by trying to cure their own health.
Which is why the physical examination is so critical. The doctor needs objective data to cut through the patient's anxiety and any damage they might have caused with those OTC products.
And what's the tool for that?
Well, the clinical algorithms from the Northeast London Primary Care Portal point to one extremely elegant bedside tool, the pH test.
Wait, so they don't even have to send a sample off to a lab and wait a week for results?
Often, no. The doctor swabs the lateral vaginal wall and applies that moisture to a narrow-range pH paper right there in the clinic.
Like middle school chemistry.
Exactly like that. Within seconds, they have a number. And the clinical flowchart for this is wonderfully decisive. If the pH is 4.5 or lower, meaning the lactobacilli are thriving and producing that protective acid, and the patient has no red flag symptoms.
Let's define those for the listener really quick. What constitutes a red flag that would override a healthy pH?
The guidelines list specific physical markers of actual disease. So vulval pruritus, which is severe, unyielding itching.
Right.
Erythema, which is visible redness and inflammation. Fissuring, meaning microscopic tears in the skin. Or a genuinely offensive fishy odor.
Got it.
If those physical markers are absent and the pH is safely at 4.5 or lower, the doctor's flowchart points to a definitive conclusion. Quote, no further investigations needed. Reassure likely physiological.
But wait, I have to ask. You're saying a doctor can just look at a piece of yellow pH paper, see there's no severe redness, and dismiss someone who is sitting there in genuine psychological distress. That sounds incredibly dismissive of the patient's lived experience.
It would be dismissive, definitely, if they just sent them home with a pat on the back. But the guidelines recognize that genital focus is deeply tied to psychological distress.
In what way?
Well, the BIHH guidelines point out that genital discomfort is highly associated with anxiety and depression. The mind has completely convinced the body that something is terribly wrong. So the treatment, when the diagnosis is you are perfectly healthy, is actually a robust medical intervention in itself.
What does that intervention actually look like? If the prescription isn't a pill or a cream, what is it?
It is intensive education and lifestyle management. The guidelines explicitly mandate that, quote, education about normal physiological vaginal discharge and fluctuations in consistency and odor may be needed.
So the medical intervention is essentially a targeted biology lesson,
Exactly. It's handing the user manual back to the patient and showing them how to read it.
paired with deep evidence-based reassurance, I imagine.
Yes. The clinician uses that pH test to prove to the patient that this condition is not infectious, and it is not a sign of cancer. In many cases, providing that objective proof lifts a massive psychological burden that was manifesting as physical hyperfocus.
It's amazing to think that sometimes the absolute best medicine a doctor can provide is giving the patient clinical permission to just stop worrying and stop intervening.
Just let it be.
Right. Just put down the soap, throw away the pharmacy creams, and let the body run its own programming.
That is the core of the vulval care advice mandated across all these sources. Clinicians must advise patients on how to step back, and the rules are incredibly uniform across the board.
What are they?
Do not douche. Wash the area only with plain water. If you must use something, use a gentle emollient instead of harsh scented soaps.
Makes sense.
And avoid tight synthetic clothing that traps heat. Stick to breathable cotton underwear.
It's all about removing artificial disruptors. Just let the coral reef breathe. Now, there is one specific exception in the sources where the doctor does have to prescribe active management. That brings us back to the low estrogen state of menopause.
Yes. This is known clinically as genitourinary syndrome of menopause, or GSM.
What is physically happening to the tissues in GSM that makes it different from just a normal low estrogen day in a younger person?
In GSM, because the estrogen levels have permanently dropped, the tissues of the vagina and vulva literally become thinner, less elastic, and more fragile.
Okay, so structural changes.
Exactly. The blood flow to the area decreases. The glands stop producing that protective baseline moisture, meaning the lactobacilli diminish, and the pH rises. It causes genuine physical dryness and irritation that isn't just in the patient's head.
So the body just isn't producing enough moisture to maintain the ecosystem anymore. How do the guidelines handle that?
The British Society of Sexual Medicine guidelines recommend using vaginal moisturizers at least twice weekly. But even here, clinicians have to be incredibly careful about not disrupting whatever natural ecosystem is left.
This was one of the most technical but honestly fascinating details in the statutory. The sources specify that any lubricants or moisturizers used must have a very specific pH and osmolality.
Yes, that is crucial.
But what does osmolality actually mean in this context? Because that sounds like pure textbook jargon.
It is jargon, but the mechanism is vital. Osmolality basically refers to the balance of water and dissolved particles, like salts and sugars, in a fluid.
Okay.
Think about it like this. If you put a living cell in extremely salty water, the salt pulls the moisture out of the cell and the cell shrivels up.
Right, simple osmosis. That makes sense.
So if a vaginal moisturizer has a high osmolality, meaning it's too concentrated with solutes, it will actually pull water out of the vaginal tissues to balance itself out.
Wait, what?
Yeah, so a patient uses a lubricant to cure their dryness, but the chemical makeup of the lubricant actively dehydrates their cells, causing more damage.
Wow. So the guidelines are saying you have to use a moisturizer that perfectly matches the cellular balance of the tissues so it actually hydrates them instead of turning them into raisins.
Exactly. The moisturizer must mimic the body's natural baseline as closely as possible.
That is wild.
The entire goal of medicine here, whether dealing with health anxiety or GSM, isn't to override the body. It's to support the body's original evolutionary design.
So as we wrap up this deep dive, think about what this means for you, the listener. If there is one major takeaway from reading through these clinical protocols, it's that understanding the dynamic, ever-changing nature of our biological ecosystems is the absolute best antidote to health anxiety.
It really is.
Your body is not a static piece of machinery. It is a living, breathing, shifting environment. A fluctuation in moisture, a change in texture, a shift in the weather. These aren't failures, they are adaptations.
And if we connect this all back to the bigger picture, I want to leave you with a final thought based on the NHS Lothian policy, which I found to be the most profound insight in the entire stack.
Oh, what is it?
The policy states plainly that if the body did not produce these natural secretions, the vagina would rapidly fill with dangerous pathogens and become severely, perhaps dangerously unhealthy.
Without the very fluid that people are panicking over, they would actually be in real medical danger.
That is the ultimate paradox. The
But
very fluids that society has historically stigmatized as unclean, the very natural physiological processes that have prompted decades of aggressive marketing for scented douching products and feminine hygiene washes, are actually the body's ultimate built-in defense mechanism.
it's just so backward.
It presents a tragic cycle, really. The societal pursuit of artificial, sterile cleanliness is exactly what destroys our natural biological purity.
The pursuit of artificial cleanliness destroys natural biological purity.
Ah, I love that. It brings us right back to the beginning. Sometimes the anxiety isn't coming from a broken body. It's coming from a broken understanding of how brilliantly the body is already working to protect you.
Well said.
The X-ray machine might not show a broken bone, but a simple piece of pH paper can show a thriving, self-sustaining ecosystem. You just have to know how to read it. Thanks for taking this deep dive with us. We'll catch you on the next one.